Michael Platten is currently the chairman of neurology at the University Hospital in Mannheim, Germany. He's also the chair of the scientific committee of our society of eEANO. Michael has received a very good education, actually, I would say, in neuro-oncology. He did his MD thesis with the famous neuropathologists in Bonn that are still with us and shaping the WHO classification. And in the first years of his training, he was not really sure whether he should solve the problem of MS or of glioblastoma. Maybe looking back, Michael, MS would have been more rewarding, but I think that's too late now. And something very specific about Michael is always the depth with which he tries to solve a problem. And I think a few years ago, he has decided that IDH mutant glioma is his enemy, and he's going to do everything now to design a new treatment for IDH mutant and glioma. And many of you have followed his work, but I think today he's going to give us a little bit broader view on what's going wrong in the field of immunotherapy for gliomas. Michael, it's all for you now.
Yeah, thank you very much, Michael, for the kind introduction. It's a pleasure and an honor to give you an overview on our work where we are trying to clinically tackle some of the questions that revolve around brain tumor immunotherapy. These are my potential conflicts of interest. What I would like to discuss with you today are essentially 4 questions. So when we're employing, and this is what I will be discussing today, the adaptive immune system, so similar to what Peter has mentioned, if you believe that T cells are the ultimate effector arm, so what are the challenges when employing the adaptive immune system for immunotherapy? What do we target? What should we target? How can we target this? Which is the patient population to target, and how to assess response? This is more the overall picture of the different types of modalities that are currently being employed. Peter already mentioned the increasing area of checkpoint inhibitors, which are nothing but antibodies that bind to cell surface molecules, either on T cells or on tumor cells or an antigen presenting cell, with the aim of releasing a break from the T cell. So it's basically a broad activation signal or disinhibition signal that is conveyed to T cells. Hence, we encounter oftentimes difficulties with respect to autoimmunity. More specifically, there is an increasing area of research revolving around so-called CAR T cells, so chimeric antigen receptor T cells. Those T cells are made from patient autologous T cells, bind to cell surface receptors that are present on tumor cells. It's an approved therapy for lymphoma, and there are several types of cell surface molecules that are currently under investigation for gliomas, and these are listed here. I should also mention that not only T cells can be engineered to express CARs, but also NK cells. And then this is what I would focus on. The majority of my talk is the question, can we identify antigens that specifically signify tumors that are presented on MHC class 1 or MHC class 2 molecules and tumor cells, so antigen presenting cells, and which are specifically recognized by T cells. Broadly speaking, these antigens can be divided into 2 different types of categories. One would be the tumor-associated antigens, and here are some of the examples that are currently being targeted also in clinical trials. So antigens that are usually expressed during development or even host tissue, like VEGF receptor 2, and are not specific for tumor. The disadvantage obviously being is that they have undergone during development some sort of tolerance with respect to the T cell compartment, and different from that are the true tumor antigens. And we have some listed here, with the advantage of them being really tumor specific, and the disadvantage is obviously being that the vast majority of those tumor antigens, which mainly derive from mutations or post-translational modifications, are not only tumor specific, but are specific for each patient, necessitating personalized immunotherapy approaches. One aspect that is important if you address the question how to activate the adaptive immune system for tumors is the clonality of the respective antigens. And here, I think, lies one of the biggest problem of gliomas, because we know from numerous studies, and this is taken from the beautiful study done by Mehdi Touaa and Keith Ligon, the gliomas usually evolve subclonally, meaning that as opposed to many other cancers like colorectal cancers, during the evolution with usually a low mutational burden, and also as a result of the pressure that we oppose by treatment, for instance, radiotherapy, but also temozolomide, you increase the net mutational burden of those tumors, but the majority of these mutations are subclonal. So what you find in a situation, particularly in a relapse situation, is you can arrive at a high mutational burden, but you will find only few clonal neoantigens. And then you basically face the same difficulties as when trying to employ a targeted therapy, is you will only arrive and target a fraction of the tumor cells. So this is one of the reasons, and I will discuss with you based on the work that we have done on immunotherapy of IDH mutant gliomas, the clinical challenges that we're facing in the field in general. So this was basically the basis of our idea, so if we want to be successful, what we would like to do is target clonal neoantigens, ideally antigens that derive from driver mutations. And here are two examples. One is mutant IDH. The other one, which I will not talk today about, is our work on histone H3 K27M mutations. And you will appreciate that even though you may find acquisition of subclonal mutations, all the tumor cells through the development will always carry these clonal driver mutations. So when we initially started to look at it, we wanted to focus on the human immune system, which is why we did experiments where we vaccinated mice that carry human MHC class 1 and MHC class 2 alleles, in this case human HLA-A2 and human DR1, and vaccinated those animals, and then took out the splenocytes and re-challenged them in vitro with different types of peptides. And what you can see here is that after vaccination of animals with a peptide covering the IDH mutation, we could see specific gamma interferon production of splenocytes in response to the mutated, not the wild type peptide. And we could also define by using different peptides where the position was altered of the mutation, is that we saw the best response in essence when the mutated amino acid was in the middle. What we also saw is that in those animals, when we re-challenged the mice, not with longer peptides, which bind to MHC class 2, but with shorter peptides, which bind to MHC class 1, we couldn't re-stimulate the cells. So this was one indication that we weren't generating CD8 T-cell responses, but CD4 T-cell responses, so T helper cell responses. And another piece of evidence then came from in vitro assays where we took the mutation-specific T-cell response and then use different types of antibodies, a class 1 blocking antibody or class 2 blocking antibody, and only in the context of the class 2 blocking antibody we could completely abrogate the response. So this was an indication that the vaccination induced mutation-specific T helper cells, so CD4 positive T cells. And what we also saw is when we took the serum of those mice and addressed the question, do we see antibodies that are mutation specific? We were able to see after vaccination mutation specific antibody responses, as you can see here. After restimulation with the after plating the mutated peptide, but not the wild type peptide. So in essence, this fits. We're kicking off a CD4 T-cell response, and we're seeing mutation-specific antibodies after the vaccine. So next we looked in patients, so patients with IDH mutant and IDH wild type gliomas, and addressed the question, do we see spontaneous T-cell responses and spontaneous antibody responses? And the answer is yes, in a few patients with long disease duration. So these were all not newly diagnosed patients. We see mutation-specific T-cell responses spontaneously arising in patients. And also here, this is an example from one patient. This mutation specific T-cell response is highly dependent on MHC class 2. So in essence, we're seeing CD4 T-cell responses. And also in a subset of patients, we observed spontaneous antibody responses that were specific for mutant IDH. So this was very, very encouraging, although we did not generate CD8 T-cell responses. And the a decisive experiment was then in that specific MHC humanized mice, the implantation of syngeneic, in this case sarcomas, that carried the IDH mutation, and animals that were then vaccinated with the mutated peptide, and this was capable of controlling the growth of these IDH mutant subcutaneous tumors, and more importantly, supporting the evidence that this is a CD4 T-cell driven response. When we treated the mice with a CD4 depleting antibody, the control of tumor was completely abrogated. And interestingly, also when we deplete B cells, so anti-CD19 antibody was also capable of abrogating the response, indicating that it's a interaction or cooperation of CD4 T cells and antibodies that help control the tumor. So this was then sufficient evidence to kick off a clinical trial, the NOAH 16 trial, where we utilized or enrolled patients with IDH mutant gliomas that were otherwise signified or enriched for a malignant phenotype based on ATRX loss and based on WHO grade 3 and grade 4. It was a multi-center clinical trial, and the investigators were free to choose the treatment. At that time, combined radiochemotherapy with temozolomide was not standard of care, although the vast majority of the patients in NOAH 16 received combined radiochemotherapy, but there were also few patients who received radiotherapy only or temozolomide only. After the initial round of treatment, patients were then screened, and only if they didn't show any signs of progression or pseudo-progression, they were enrolled in the clinical trial. And then in parallel, in the majority of patients to the adjuvant temozolomide, patient received in total 8 peptide vaccines over the course of 24 weeks. And then were followed up with intense immune monitoring, MRI, and assessing of safety. So in essence, these are the results of the clinical trials. 249 vaccines were administered to 32 patients in total. So the vast majority of patients received all 8 vaccines. We didn't observe any regime limiting toxicities. The vast majority had treatment-related adverse events, but none of these events were severe, and the vast majority were local reactions to the injection of the vaccine, which was anticipated because it was a peptide vaccine that was emulsified in montanide, and this typically creates local immune reactions. So the safety endpoint was met, but also the immunogenicity endpoint was met in that 28 of 30 patients So 93.3% displayed IDH vaccine-induced immune responses. And you can see here the heat maps of the patients that were classified as T-cell responders or non-responders, and also patients who generated an antibody response. What's interesting to see is that we could see specific T-cell responses as early as 6 weeks after the first vaccines, and typically for the antibody response, it took a bit longer for them to appear. This is the clinical course displayed in the swimmer plot of the patient population, as you can see here. So in the whole cohort, 3-year progression-free survival was 63%, and this 3-year overall survival was 84%. What you can see here is that if we divide the population between those who mounted a specific immune response and those who did not mount a specific immune response, those who did not display a T-cell response had a worse progression-free and also overall survival than patients who did mount an immune response. So this takes me to the question, whom to target? And a very interesting question that we have been thinking about a lot is, do we need presence of the antigen? So do we need a residual tumor, or what has been classified as bulky disease? And then we'll also briefly talk about steroids in the next part. So I'd like to refer you to the study that was published by Michael Platten in 2017, a phase 3 clinical trial that employed a vaccine targeting the variant 3 of the EGF receptor that was done in patients with newly diagnosed glioblastoma. Also here, this was implemented or integrated into standard of care. And what the study showed is that the target population, which was at that time minimal residual disease, so patients who had less than 2 cubic centimeter of tumor, this patient population did not display a response to the vaccine. But there was a almost significant a signal that patients who had a significant residual disease, i.e. tumor after resection of equal or more than 2 cubic centimeters, that in this patient population, there at least was a trend that they of response. And the authors followed in that paper that patients with more substantial residual disease expressing the target antigen might experience greater response from generation of targeted immunity than those with completely resected disease. So a general remark that we may need a relevant tumor in the brain in order to be effective with an immunotherapy. So we looked at that in the NOAA 16 cohort that is much smaller than in this trial, obviously. But what we could see, and I still think that this is an interesting signal, if you look at the progression-free and overall survival in this study cohort, and look at patient population that received complete response, which was 53% of the patients, a subtotal resection, a complete resection, so 17 patients, subtotal resection, this was 12 patients, and then a biopsy, which we know is a highly prominent negative predictor for outcome in patients with gliomas. So by and large, these 3 patients did better than the patients who underwent a complete or subtotal resection. It's an interesting signal. It's a small cohort. It's only 3 patients, but I think that it may support the evidence that you need presence of the antigen in order to generate a sufficient immune response. So we were interested in the question, and I think that that's something that we wanted to explore more also in the NOAA 16 trial is, do we really need the antigen, and what's the impact of the antigen? And the best way to show this is to actually have evidence and be able to quantify antigen presentation in the tumor tissue. And this goes back to a paper that we published a couple of years ago, and something that actually Felix Sam initially came up with an idea, and then we conducted that in a series of patients, is can we prove that the IDH peptide is presented on MHC class II molecules in situ, so in tumor tissue. What Felix conceived is an assay that is called proximity ligation assay, and what it does is it utilizes an antibody that binds to MHC class II, and the antibody that is being used for diagnostic purposes that binds to mutant IDH. And then what this assay does is, using secondary antibodies with nucleic acid stretches attached to them, who anneal if in proximity, and then with a rolling circle amplification PCR that you can do in situ with fluorescent nucleotides, you can basically generate and visualize a signal in those tumors. What we had to show, and this is done here, is that the antibody actually recognizes mutant IDH in the context of MHC class II. And this is the data that you can see here, where you can basically neutralize the antibody response by titrating in the antibody. So this shows that the antibody really recognizes the mutant IDH also in the context of MHC class II. And this essentially shows what we have been seeing is these red dots indicate proximity of those antibodies. So as a surrogate of antigen presentation of the peptide on MHC class II. And it seemed to be that this is a highly specific assay that is capable of indicating presentation of this antigen in the tumor tissue. So we looked at that in the NOAA-16 trial, and what we tried to do, and this is mainly work by Lukas Bunse. He developed as a surrogate of a mutation-specific immune response, and you can see here the ELISpot results of 2 different patients in that clinical trial from the first visit to the last visit. You can see here in red the mutation-specific Tser response, ELISpot response, and the response to the wild-type peptide. So this would be a responder, and here you wouldn't see any difference, so no spots, so this would be a non-responder. And the mutation specificity score is basically nothing else than subtracting the response to the wild-type from the response to the mutated peptide in this ELISpot assay. What you can also see is that this mutation specificity score is predictive of outcome here as measured in the overall survival, which was reduced in patients with a low mutation specificity score as opposed to those patients here in red with a high mutation specificity score. But what was really interesting, and you can see here that there was a high discrepancy between different patients. You can see here one patient where we see a very strong signal, a lot of these red dots indicating antigen presentation, and we also had patients who buried or carried the IDH mutation, but where we didn't see a relevant amount of antigen presentation. And if you plot the relative value of this PLA signal indicating antigen presentation against the mutation specificity score, you can see a linear relationship, meaning that the mutation specificity score increased with the presentation of the antigen as measured by the PLA signal. So this is a very interesting evidence that antigen presentation seemed to matter when it comes to a peripheral immune response against an antigen that you vaccinate the patient against. A brief mentioning of steroids, which are obviously a relevant bottleneck. And in most studies, such as the ACT-4 trial, patients were limited with respect to dexamethasone. But here in this study, more than 2 milligrams dexamethasone per day were not associated with worse outcome or decreased tumoral immune response. But in other studies, such as the Checkmate 143 study or the NeoVax study, there was at least some indication that steroids conferred a decreased immune response and a worse overall outcome, also when you look at patients with melanoma brain metastases. But this is really circumstantial evidence. Again, what we have seen in the NOAA-16 trial, the dexamethasone at baseline as a study entry criteria was limited to 2 milligrams per day. We had only 2 patients who received dexamethasone at baseline. And what we interestingly saw is that at least in those 2 patients, what we can say is that they were capable of mounting a specific immune response, although it's because of the small numbers not possible to differentiate whether this was decreased, but at least we saw a specific immune response. But those 2 patients experienced early progression at 9 and 21 months. So the question is, can we measure a peripheral immune response, but what's the efficacy of this immune response? But I think that due to the small numbers, this question is still unanswered. So in the last part of my talk, I would like to address the question, how do we assess, and I think that this is a very important topic, how do we assess whether we are inducing a effective intratumoral immune response, and whether this is specific. Do we see tumor infiltration with specific T cells? And I would like to start discussing this with the clinical trials that were done with checkpoint inhibitors. So in this case, the Checkmate 143 study, which most of you know has been a negative study to the comparator, which was bevacizumab in patients with recurrent glioblastoma. There was no survival benefit of nivolumab. And a study that was recently published, a randomized study by Tim Clausey and Rob Prince, who utilized neoadjuvant pembrolizumab. So patients were randomized between adjuvant and neoadjuvant, meaning half of the patients received pembrolizumab before a pre-planned resection, and half of them didn't. So all patients underwent a resection. And this is a sort of window of opportunity trial design that then allows to assess the effect of the checkpoint inhibitor in this case. What was interesting is that the study showed that all in all, the patients who received neoadjuvant pembrolizumab fared better than the ones who received adjuvant temozolomide. And it may again be contributing to the hypothesis of the necessity of bulky disease or significant disease at baseline for an immune response to become effective, because the checkpoint inhibitor is nothing else than reinvigorating pre-existing tumor-specific T cells if it is effective. So what they have shown in detailed analysis of the T cell receptor repertoire, which is shown here in right, and the transcriptome of the tumor, is that there were more patients in the neoadjuvant setting who displayed an immune response as measured by induction of interferon downstream genes, induction of T cell activation genes, and also the enrichment of clonally expanded T cell receptors. And it's interesting. It's a small signal, but at least it shows that checkpoint inhibitors, so the activation of tumor-specific T cells, translates into effects in the tumor tissue that can be measured. And I think that this is very important. We have tried to address this in a preclinical model, which we have published last year. It's a very simple, straightforward intracranial GL261 model, very standard. And we randomized the animals based on MRI and treated one group with anti-PD-1 and anti-CTLA-4 antibodies, and one group with control antibodies, and then performed serial MRI imaging. And what you can see here is that even in this syngeneic mouse model, we see response and non-response to immune checkpoint blockade. So we see a fraction, about 50% of the animals that responded to immune checkpoint blockade, but we see a similar size of a fraction that does not respond. And this is a very interesting observation because at least focused on this experimental model, it tells us that it cannot be the antigen because it's syngeneic tumors, and we did a lot of control experiments on that. It can also not be the microenvironment because this is also similar. But the factor that determines response and non-response must lie in the stochastic distribution and evolution of the T-cell receptor repertoire, because this is the only thing that can be different between animals. So at least on the efferent side, it's the T-cell receptor repertoire that in this model seems to matter and determine response and non-response. I think that the question that is very interesting for determining and implementing immunotherapy is how do you predict response based on non-invasive parameters. You all are familiar with the eEANO criteria. So basically, you allow a longer time window for pseudo-progression, but this is unsatisfactory because you're basically blind for a long period of time with respect to does the therapy work or not work. So we would like to have an early indication of the question, if I do an MRI, can I use this in order to predict response to that? So we have utilized, with the help of Philipp Kickinger, Martin Benschus, and Michael Breckwold, to utilize the T2 imaging of those mice with the experimental gliomas and extracted 423 radiomic features and tested them for the predictive value for response and non-response. And what we can see is that when doing this, the signature allowed to predict treatment response with an accuracy of 82.7%, which is certainly better than nothing, something that needs to be improved. And as we progress in the clinical situation and may become more successful, this is something that would be very valuable when translating into the clinic. For the time being, in the NOAA-16 trial, we have assessed pseudoprogressions. We saw in a significant number, in 12 of 32 patients, pseudoprogressions, and be reminded that one entry criteria for the study was the absence of pseudoprogression. So patients were entered at the time when we see the majority of pseudoprogressions. So there's reason to believe that those pseudoprogressions are the result of an immunotherapy, particularly of the vaccine, particularly when we compared this to a molecular matched control cohort where we saw this only in 16.7% of the patients. When we address the question, relation of the pseudoprogression to the immune response, we see in the majority of patients, all but one, the pseudoprogression at the time of the early response or later. So again, supporting that this is something that is driven by the immune response that we can measure in the periphery. You see here on the left side one example of a patient that has experienced a pseudoprogression here on FLAIR imaging and here magnified with a transient contrast enhancement that was seen at the resection cavity. Now, interestingly, when we differentiate a transient is sustained or no immune response and ask the question how many of these patients have experienced a pseudoprogression, we saw this in more than 50% of patients who experienced a transient immune response, a third of patients who experienced a sustained immune response, and not in patients with no immune response. So again, correlative evidence that this is due to the immune response, but it was interesting to see that we saw this in the majority of patients who only had a transient immune response. So this may be taken as an indication that the T cells that we're seeing circulating in the periphery disappear from the periphery and then ideally home to the brain tissue. This is something that we see a lot when we work with experimental models of CNS autoimmunity. So it is key to look at the tumor tissue post-treatment. This is what we've done in the animal study with the MHC humanized mice, where you can see that in the vaccinated animal, in the post-vaccination tumor tissue, we see an increased infiltration with CD3 positive T cells quantified here. And when doing tetramer analyses of these CD3 positive T cells, in this case, 2% of those were reacting or binding to the tetramer, indicating specificity for the antigen. So of course, we were interested in trying to interrogate patients from the NOAA-16 study we had, and this is an example of one patient who got re-resected in a situation where there was uncertainty of progression versus pseudo-progression. And we were able to use the tumor tissue and perform single-cell sequencing, where we interrogated not only the transcriptome of the T cells, but also the T cell receptor repertoire. So what you're looking at here is a division of different groups of T cells infiltrating the pseudo-progressed tissue. So based on the transcriptomes, they were clustered in different types of clusters. And what you see here is individual clones, so top expanded clones. So what we're looking at is the representation of the most frequent T cell receptors that we identify. We were much more interested in the CD4 T cell receptor repertoire, because this is where we were looking for IDH specific T cells. And of the top 5 CD4 positive TCRs, there was one particularly clone that stuck out that was very high in expression of CD40 ligands and also CXCL13. So these are activation markers. You can see here in this UMAP plot the small population of CXCL13 CD4 T cells. So this is where the top clone resides in, with a very peculiar transcriptional profile. And this is a plot that maps the clonality of the CD4 compartment against the peripheral compartment at visit 7 from the same patient. So looking at the productive frequency. And this is just to show that we not only see this clone coming up in the tumor tissue, but also in the peripheral circulation as something that is induced by the vaccine. So we took those T cells, we cloned the T cell receptor, and then we tested this T cell receptor for reactivity, which you can see here on the right-hand side, and notice that when doing this T cell receptor specifically recognized the mutant IDH. So it basically was a validation that the vaccine induced IDH reactive TCRs in the periphery that were capable of homing to the tissue. And at least for this small population, we could provide evidence that these maintain or retain an activated phenotype in this pseudoprogression, which may, and coming back to what Peter has indicated, over the course of the disease with the tumor microenvironment turn into exhaustion. And I think that this is an important issue that we're trying to tackle, particularly in IDH mutant gliomas. This is just showing that the immune microenvironment is very peculiar in these types of tumors, which is, we believe, as a result of the production of 2-hydroxyglutarate. What we can see here in this study that we've published in 2018, but also more recently, is that immune cells present in IDH mutant gliomas have a specific, and as we have shown, immunosuppressed phenotype on the basis of the transcriptome. So you can identify the T cell expression profile based on the question whether they reside in IDH mutant or IDH wild type gliomas. And we also see here, this is collaboration that we did with Marco Prinz at the University of Freiburg and Josef Priller in Berlin, using human single cell sequencing and cytoph analyses of tumor infiltrating myeloid cells, that in IDH mutant gliomas, there was a suppressed capacity of antigen presentation in IDH mutant glioma. So this is certainly an indication that these T cells, if anything, in that microenvironment hit an immunocompromised compartment. This is the last piece of data from this paper, and I think that this is also very important when we're looking at these types of studies, particularly single-cell sequencing analyses. In the absence of very good and robust, but I'm certain that this is coming, spatial omics data, we will have to acknowledge that there's a great deal of heterogeneity also with respect to the tumor microenvironment. There are niche-specific phenomena. And this is one way that we try to address, and this is data that were generated by Carsten Hopf from the Multicenter, the University of Mannheim. You can see here that you can quantify the 2-hydroxyglutarate production in IDH mutant, IDH wild-type gliomas. Obviously, you have the signal is absent in IDH wild-type gliomas. And also in control cortex. But if you look at this on a spatial resolution, you see a great deal of heterogeneity in these analyses. So with respect to many microenvironmental factors, you have niche-specific phenomena, and I think that these need to be taken into account. And the way we would like, or currently trying to address this, is a window of opportunity trial that is currently accruing, where we're trying to test two different questions. So question number one would be, can we amplify the IDH vaccine by using a checkpoint inhibitor, in this case, avelumab? But the more important question is, and these are patients that are being enrolled with recurrent IDH mutant gliomas, more importantly, what is the impact of the immune intervention on the tumor microenvironment, or vice versa? Do we find specific T cells? How do they look like? And is the analysis of this tumor tissue predictive of the outcome of these patients? So this is a collaborative effort, as for the NOA-16 trials, many centers in Germany participating in that. This is funded by the German Cancer Consortium. So in essence, I think that these are the ways that we need to address fundamental questions and the clinical challenges that we still have when trying to implement immunotherapy for the treatment of patients with brain tumors. And with that, I'd like to thank first and foremost all the patients who participated in the clinical trials and donate their sample. The institutions that I had the pleasure to work in and with to conduct these trials, and the great research team that generated all these data that really helps us a lot in order to understand and foster the understanding of immunotherapy in gliomas. Thank you very much.
Thank you very much, Michael, for this excellent presentation. Lots of interesting data.
So Michael, one question that's not really related to your immune work, but to the consequences of that. Here and there, voices are being raised that if you target the mutant IDH, you simply transform them into IDH wild-type tumors that are more dangerous. And I think that's a little bit a naive consideration, but I think there is some preclinical evidence arising here and there that may not be such a good idea. What are your views on that?
So we don't have any evidence from the clinical studies that were putting an immune pressure that results in loss of the antigen. I don't think that this is, for now, a relevant problem. We have seen that in the preclinical model, but then this was different because we transfected the mutant IDH into the cell lines. I think that if we were to be that successful in putting so much immune pressure on the tumor cells that they lose the antigen, that would be first and foremost an indication of success. And the question, what happens after that, is something that I think we should take care of then, but not something that I would a priori be more concerned, particularly because we haven't seen immune evasion due to loss of antigen. And a lot of the studies that are being done in indications where people are more successful in controlling cancers with immunotherapy is not so much loss of antigen, but more loss of capacity to present the antigen, and down modulation of signaling pathways that are important in order to trigger an immune response. So these are more the types of immune invasion mechanisms that occur in these types of cancers.
But I come back to that. What is your expectation? Let's say you would eliminate the cells that express the canonical mutation, but otherwise the cells would be the same. What do you think? How would they behave biologically? Would they be more aggressive or less aggressive, or you think it wouldn't matter if you take away their mutant IDH?
I think that this is a philosophical question. I haven't seen any data that firmly establish what would happen in that situation if you really have a bona fide IDH mutant gliomas and you just take away the mutation. And I'm thinking about the preclinical studies that we have done, but I really think that this is a pure speculation. I don't know. Do you have any idea?
No, but I've also never seen patients that really show loss of antigen expression. But other people report this. There are some cases around, and there is this concern around, and that you lose the hypermethylation at recurrence. I have not seen that as a clinical problem, but I mean, I agree that, I mean, it would be a wonderful proof of concept if that happened, so it would make you happy in the first place. But the question is, what type of disease would that be in the end? And I guess you are also struggling with establishing good models from human samples, but maybe you can share also a bit of experience there, because many of us try to generate these models from the OR, and they rarely grow well.
Yeah. I think that, you know, this is obviously a problem, and that may be solved by adding certain amino acids, maybe glutamine, in order to keep the cells happy. I think it's also clear that, you know, overproduction of 2-hydroxyglutarate is per se, if there's too much, it also becomes toxic. So there's certain things that you can do in these models. But again, the question is, I think that the decisive experiment would be to utilize those human cells and have a well-working model that you can utilize in immunocompromised mice, but then you would have to go in with T cells that are specific for the mutant IDH, which we have generated and we're currently investigating. So this would be one type of experiment that in principle would be able to help answer that question.
So we have two questions now in the chat. Simone Clou wants to know what you think about the impact of T cell sequestration in the reaction to the vaccine in the IDH mutant patients.
I'm guessing that Simone is referring to sequestration to the bone marrow, yes, following up on Peter's great work. And the answer is, I don't know. So we haven't looked at that. We haven't subjected patients to bone marrow analyses. That would be interesting. But I guess she's also referring to the question transient and sustained T cell response. And it's right. So if we're seeing a transient T cell response, that the T cells may not disappear and go to the brain tumors, but also be sequestered in the bone marrow compartment. So this is certainly a possibility, but we haven't looked at that.
And then we have another question from Marta Shikenya. It's a long question, but you will like it, I guess. We all like it. Given the relatively low frequency of IDH mutant glioblastoma, would the immunotherapy strategy be targeted to lower grade tumors? How would the slower disease progression impact assessment of treatment efficacy and response?
I guess this is the same question that Agios, Servier, respectively, and many people advising these companies have been struggling with in setting up the registration trial for AG881. I think it's a difficult question, and you can solve this in a non-immunotherapy disease by doing what is being done in the Indigo trial, extracting surrogate parameters and assessing the dynamics rather than just focusing on the eEANO criteria. I think that for immunotherapy, things that we could potentially do is establishing surrogate MRI parameter, and similar to the people in the MS field do. I mean, they're basically establishing surrogate parameters of inflammation and then associating them with a specific disease cause. And the hope would be that these surrogate imaging parameters would at some point be sufficiently established, like in the MS field, that you can actually utilize them in order to assess response to these types of treatments.
Yeah, but I mean, many of our checkpoint friends have always said in glioblastoma, the treatment didn't have time to work, right? So low grade is not a bad thing for immunotherapy. And then another question that I think is also really on the table comes from Philip Wood-Smith. Have you considered IDH inhibitors in concert with the vaccination to enhance T-cell infiltration and modulate the microenvironment?
Yes. And if you would be able to facilitate and sponsor a clinical trial, I'd be up and running and do that tomorrow. This is certainly something that we're actively working on, but haven't gotten around to start such a trial.
So that was the last question I have. It's 5:30. That is good. I think otherwise we have to pray more anyway. Michaela, do you have any other question?
No, there is just one question that came in earlier, a bit more general question from the audience, from Chase Bradshaw. So they are asking, are there any findings suggesting actions patients can take to improve immune system function levels during clinical trials?
The short answer would be no. You know, the general remarks of advice, obviously staying away from immunosuppressive drugs is not a good idea if if you're prescribing chemotherapy. But in essence, this is something where I usually, if patients come with that specific questions, and particularly suggesting some supplementary ingredients that allegedly help boost the immune system, I usually advise them to stay away from these. There's certainly no study showing that any of these measures really support the immune system in a way that it is more effective or protective.
Thank you very much. Okay, so with that, thank you very much, Michael. So thank you to both speakers for their contribution. That was, I think, a very, very interesting session. So I would just like to also mention our upcoming events. So please mark your calendar for the upcoming webinar on the shared decision making within neuro-oncology, which is taking place end of August. And then, of course, the eEANO 2021 virtual neuro-oncology meeting. So thank you, everyone, for participation, especially to the speakers for this, for participation in an excellent session. Thank you very much. Bye.
Bye-bye.
Thank you. Bye-bye.